Hi, I'm Vicki Hudson, and welcome to National Dental Network's Excellence in Cosmetic Dentistry. In this program, we're proud to feature Dr. Tim Saligi, practicing in Long Beach, California, and his work has been seen by millions on the popular Extreme Makeover.
Participating with all the doctors on Extreme Makeover was probably the highlight of my professional career. You know, for a long time we've been doing procedures that on television may seem somewhat sensational, but it's what we do every day, whether it's orthodontic surgery, whether it's immediate implant placement and restorations, whatever that procedure may be, the general public didn't really have a full understanding of what was possible for them. So it was very rewarding for me to know that my specialty in dentistry in general has now become mainstream.
We join Dr. Saligi as he demonstrates advanced techniques for minimally invasive surgery for dental implants with immediate temporization.
The dental implant system we'll be using for the following three cases is the Zimmer system, specifically the tapered screw vent or TSV family of implants. As you can see here, this is a 3.7 millimeter dental implant. It's tapered. The advantage of having a tapered implant is you can very carefully place it between converging roots. Secondly, it tends to compress the bone as you seat it to full depth. The Zimmer tapered screw vent implant has the fixture mount attached to it here. And there are multiple ways of restoring this implant, and I'm going to review two of them with you now. So let me remove the pre-attached fixture mount and demonstrate the internal hex. This is a unique connection. It was the first internal connection on the market and has functioned flawlessly for almost 2 decades. In addition to having an internal hex, it also is a friction fit, which will form a virtual cold weld between the abutment and the implant itself. This virtually eliminates any type of micro-movement that can contribute to crestal bone loss over time. So the first case that we're going to demonstrate today will be utilizing a 3.7 millimeter tapered screw vent implant with an immediately placed hex lock contour abutment. As you can see here, the hex lock contour abutment looks very similar to a custom abutment. You'll note that the collar has a variable height. The lingual portion will be higher. The facial portion will be lower. And interdentally, you have a normal chamfer shape. This allows support of the papilla. It also provides for a highly cosmetic result by minimizing the facial margin. The contours and also the built-in flare provide for an ideal emergence profile. The contour abutment comes in a variety of flares and a variety of collar heights. The hex lock contour abutment gently seats into the implant and is tightened down with a 0.5 millimeter screwdriver. This can be done immediately, or it can be done in a more traditional delayed fashion. Perhaps the greatest advantage of using the hex lock contour abutment is the development of a very easy-to-use impression coping analog system. This comes as a prefabricated kit, and inside this kit you'll notice we have an analog, 2 copings, and a snap cap impression post. The snap cap impression post fits easily over the top of the abutment, and a traditional crown and bridge impression can then be made. The snap cap then will release from the abutment. A laboratory analog can then be placed inside, and this can be used to fabricate the model by your lab technician. Also delivered with this kit is a white waxing coping that the laboratory technician can use to fabricate the final crown. A temporary coping is also given with the kit and can be used to fabricate an immediate provisional. One of the beautiful things of this system is that they've also fabricated a one-piece implant. Looking at the one-piece implant, it's very hard to distinguish between it and the tapered screw vent implant with a hex-lock contour abutment in place. The unique features of the Zimmer one-piece implant are that it was principally designed off of the tapered screw vent implant. In fact, the osteotomy that is made for the tapered screw vent implant is identical to the osteotomy that is made for the Zimmer one-piece implant. This gives practitioners leeway should they have an angulation problem after creating the osteotomy. A fail-safe, if you will, that you can implement should you need to. The coronal portion of the Zimmer one-piece implant is designed based upon the hex-lock contour abutment. The most coronal portion of the one-piece implant has this notch, which is characteristic not only to it, but also to the hex-lock contour abutment, which means the same impression kits that are used for the hex-lock contour abutment can also be used for the Zimmer one-piece implant.
In this segment, Dr. Saligi will discuss the treatment plan for minimally invasive surgical implant placement and immediate temporization of a maxillary right second bicuspid.
In this case, we'll demonstrate the Zimmer one-piece implant, again placing it through a minimally invasive technique. The panoramic radiograph is the standard image that I like to use in treatment planning my implant cases. Looking at our panoramic, we can visualize the sinus. The floor of the sinus has been elevated. Using our periodontal probe, we can see we have ample bone for a 13 millimeter implant. Our interradicular distance is approximately 7 millimeters, and our intracoronal distance is approximately 6 millimeters. So going into this case, I'm planning on using a 13 millimeter by 3.7 millimeter Zimmer one-piece implant. Evaluation of our study model shows a very thick biotype, ample buccal bone, a little more than 6 millimeters of intercoronal distance. In this case, our patient lost tooth number 4 and has had a sinus graft and a socket graft about 4 months ago. So we're pretty much ready to place our implant. You know, there are quite a few advantages to doing a minimally invasive surgical technique. First of all, for the patient, you have significantly decreased swelling and significantly decreased postoperative pain. In addition to it, when we get ready to temporize these cases, there's much less bleeding, the field is drier, more secure, and we get a better immediate aesthetic result. The disadvantages of this technique are that you don't have the same amount of visualization as you would if you elevated a full-thickness mucoperiosteal flap. Now, the research is a little equivocal about this, but some people believe and have found in their studies that you have decreased crestal bone loss if you don't elevate a flap. So what do we look for when we're determining whether a patient's a good candidate for a non-invasive technique? I'll show you right now. The first thing we want to examine on this patient is our overall buccal palatal width. And you can see here we have more than 9 millimeters of bone width. If we look at our intercoronal distance, we're also at about 7.5 millimeters. So we have good space in this area to use a non-invasive technique. The other thing we want to check out is the amount of keratinized tissue we have. Our mucogingival junction is right here. So in the course of making our osteotomy, we're not going to be eroding this tissue such that we don't have a good amount of attached gingiva on the buccal aspect of the implant. We'll begin the case by giving a small amount of local anesthesia. A little infiltration in the maxillary vestibule should be sufficient, and I like to blanch this tissue slightly just to make sure we have good anesthesia. Now that we've achieved adequate local anesthesia, our first step is to try and manually determine the amount of bone available in a bucco-palatal direction. To do this, I like to use a periodontal probe and sound to make sure we have an adequate amount of bone. We have solid bone clear out on the buccal, and we have solid bone at the crest. The other thing that's important to determine is your overall thickness of gingiva. As you can see in the mid-osteotomy range here, we have about 3 millimeters of gingival height. This is important to know because when we make our osteotomy, we'll have to add an additional 3 millimeters onto the depth that's indicated on our surgical drill. The first drill we're going to use to start our procedure is a tapered pilot drill, also known as a Christmas tree drill. It has a very sharp tip, and it's great to use to initiate the osteotomy. You can note that I have positioned the drill in the middle of the osseous crest, equidistance between the molar and the premolar, trying to parallel, as best I can, the roots of the adjacent teeth. Ready? This site has been grafted with Puro's mineralized cancellous bone about 4 months ago, and we really have good resistance to our drill. The tapered pilot drill allows us to initiate our osteotomy without a lot of chattering. It engages the bone very well. So when we go to our initial 2.3 millimeter pilot drill, it passes through very precisely. To determine the depth of our osteotomy, the pilot drill is etched, and the etchings are as follows: 8 millimeters, 10 millimeters, 11.5 millimeters, 13 millimeters, and 16 millimeters. As we mentioned previously, we're planning on placing a 13 millimeter implant in this area. Now remember, we have approximately 3 millimeters of gingival tissue on the crest, which means as we drill, we'll be drilling to this final line right here. The level of the bone will reach this line right here, which is 13 millimeters. So now we've taken our initial pilot drill, the 2.3 millimeter pilot drill, to 16 millimeters of depth. At this point in time, I like to use a guide pin to confirm that our angulation is perpendicular to the crestal ridge. It's also good to use the guide pin to determine our occlusal position. So for this, we remove the bite block. Open, please. And have the patient close down gently. In this case, you can see we're slightly angled to the buccal, which we'll be able to correct with our subsequent osteotomy drill. The next drill that we'll be using is a 2.8 millimeter twist drill. This drill can be used as an intermediate drill, or in soft bone cases can be used as the final drill to ensure that we have good contact between the implant and bone when the implant is placed. I like to double check my angulation now that we corrected it using the guide pin placed in the opposite direction. Notice the wider portion of the guide pin is in place and to depth. Open, please. And gently close. Relax your jaw and close. And we're in a more ideal position now. Because we've previously grafted this site, and because it's maxillary bone, more like D2 type bone, I think we'll go ahead and place the implant using the soft bone technique. Prior to placing the implant, I like to take one final check of the osteotomy using a periodontal probe to make sure that all of our walls are intact and that we haven't perforated the maxillary sinus. We can also see that our osteotomy is nicely in the center of our crest, equidistance between the adjacent teeth. We'll be using a 3.7 millimeter by 13 millimeter Zimmer one-piece implant. It comes packaged like the standard tapered screw bed implant and has an internal driver. The flat side of the driver corresponds with the most labial portion of the contoured portion of the implant. It snaps into place and is easily removed from the packaging. Prior to placing the implant, I like to place just a little saline on it. It acts as a lubricant and prevents it from binding as you're inserting the implant. Go ahead, Edie. A little bit of saline. There we go. Open, dear. Each rotation of the Zimmer one-piece implant will seat the implant 1.2 millimeters apically. This allows you to carefully control the position of your margin. Now that we have the implant completely seated, we can double check our facial margin. We follow the margin down along the facial, and you see we have approximately 2.5 to 2 millimeters of gingiva covering our margin, which will give us an ideal cosmetic result. Also note, we're almost exactly equidistant between the two teeth. At this point in time, with the implant in its final position, we can take an impression, which the lab can use to manufacture the final crown. The Zimmer one-piece implant comes complete with its own impression kit. To take this impression, we'll simply snap the snap cap in place, take a standard full arch impression, and send it to the lab for manufacture of a crown. This is a regular body polyvinyl siloxane impression material. And it's here principally to identify the gingival margin. We've let our impression set. Let's see what we end up with. Here is the result of our impression. We have good gingival architecture, and you can note that our snap cap is locked firmly in place. This is convenient because we don't have to worry about getting an impression of the margin, which is nicely subgingival. Included in the kit is a laboratory analog, which can be placed into the snap cap. This model will then be poured up by the laboratory technician and the final crown manufactured. Also included in the kit are two copings. The buff-colored one we will use to manufacture our temporary. The white-colored one is our burnout coping, which will go to the lab along with the impression and the analog for fabrication of the final crown. Preformed ion crowns are ideal for making chairside temporaries. The first step is to find the ion crown that's best going to fit in the patient's mouth. With our provisional coping in place, we're going to simply try in the ion crown over the top, placing it right directly over the coping and pushing gently. And it looks like that will work nicely as a chairside temporary. The other advantage of using the Zimmer one-piece implant is the impression that we've taken and we're going to send to the lab can be used to manufacture a lab quality temporary that the patient can wear for several months prior to switching it over to the permanent crown. Because the inside portion of the ion crown and the outside portion of the coping are smooth, I like to rough them up a little bit with a burr. We're also fitting slightly tight, so this will allow it to fit just a little bit better inside the mouth. And I'm also going to reduce down the occlusal slightly. And now I'm just going to roughen up the internal portion of the ion crown so our flowable sticks well. I'm also going to reduce it slightly to accommodate our coping. And into our ion crown we'll place a little bit of flowable composite. This then is passed over the top and held in place, and we'll cure it with a curing light. This then will capture the position of our coping. Here we see the ion crown. We've captured our coping. I'm going to simply place that coping onto our analog and add